This week on the BackTable podcast.
I think identifying patients with chole tubes that are not coming out because of gallstones and they're never gonna have surgery, that's an easy place to start. Also, doing the intrahepatic biliary work, being available to either scope and get a biopsy or scope and maybe get rid of a choledocholithiasis that GI can't get to. Things like that will kind of get your foot in the door, get the conversation started. And after you've done a couple of these, it'll kind of spread around the community that, this is a service line that IR can do. It fills in some gaps that are there for patients. And it's a very, I think, meaningful procedure that is still evolving, but we're trying to get more and more people doing it and more people comfortable in it.
This is Michael Barraza, return as your host. I'm joined by my friend, John Smirniotopoulos from MedStar Georgetown. John, how's it going?
Good. Thanks for having me. Glad to be back.
Yeah, thanks for coming back. So today we're going to talk about biliary endoscopy and specifically focus on the stuff you're doing in the gallbladder. So what I wanted to do is just start off with, when did you start doing this and how and why?
Yeah. So we started doing this in 2020, about 5 years ago. That's around the time that there was FDA approval for the Boston Scientific Spyglass Discover. So that's a cholangioscope. It's born out of the original Spyglass, which is used in GI. It's a shorter scope, and I think it was initially designed for surgical use, so intraoperative lap choles. They'd run the cystic duct and CVD. What they found is that IRs liked using it more, and so they started talking to IRs about it. And so the first time we really started going into cholangioscopy for the gallbladder, I think I was back at Cornell as an attending, and Bill Brown there, he and I were identifying some cases of patients that had cholecystostomy tubes and gallstones and were never going to have surgery. So they would keep coming back every 3 months for a chole tube exchange and maybe cap them, maybe remove it. There's a 30% risk of recurrent infection with indwelling stones. And so we were trying to figure out creative ways to get rid of the stones so they could get rid of the tubes and improve their quality of life. And so we discussed about, how can we do this? How can we put a camera in there? And before we had Spyglass Discover, we were using ambu scopes or disposable bronchoscopes, cystoscopes, things like that with little kind of iPad displays. And really that's where it started taking off, was those experiences in New York in 2020, and subsequently going into larger stones, more complex stone removal with different equipment. And that's grown. It grew when I came back to MedStar in 2021 and has just kind of continued to expand. And I think what really helps from my perspective is having a good collaborative relationship with our surgeons because they know that we can do it. And they don't also want to have these patients needing to come back to their clinic saying, am I a surgical candidate today? And no, you're never going to be. So having a solution for those patients is helpful. And it's gotten to the point now where our surgeons will actually include it in their note if they get consulted, please contact Dr. Smirniotopoulos for consideration of what I call ghost scope, gallstone organ sparing, percutaneous cholangioscopy and extraction. So it's been good. It's been built up. Yeah. So I do a lot of stone work now.
So did you do any cholangioscopy in training?
I think I did maybe one or two with the original Spyglass at the very end of training when we knew that the Discover was going to be coming out. And we did it in the biliary system, looking at where there was evidence maybe of disease, pathology, cancer kind of ingrowing for biopsy sites. So we did maybe 2 cases when I was at Georgetown, I think with Emil Cohen and Alex Kim at the time.
Yeah, I think I did one cholangioscopy case in all of my training. It was this giant scope that was not made for this. It was before Spyglass. And so the reason for that question is what was it like, kind of taking that on and expanding this in your practice without a ton of experience? And I know that honestly, it's one of the things about interventional radiology. We're always taking on something new, but I always like to ask people, how did you do that?
Yeah, so the initial ones in New York, we just kind of played around with the scope a little bit. You had a rep come in and you just figure out the dials. They're somewhat intuitive. Spyglass, I like to describe it, you don't go up and down, side to side. You kind of go at the corners And then you have a rotational component. So there's a little bit of a learning curve, but it was, talking to the reps, seeing it off the table first, kind of just getting your bearing straight. And then honestly, just doing the case and kind of getting experience with it. And after a while, it becomes a little more intuitive to use, but there's a learning curve for all this stuff too. At this point, if there's someone that's doing it, they can hopefully teach you and show you how to do it. There are now, webinars where IRs are teaching people how to do these things. At SIR, we've had several sessions. A lot of this pioneered by Harjeet Singh out of Hopkins, who's really made such a really global effort to get cholangioscopy on the IR's radar. And so there's a lot of resources out there. But when we started, it really was kind of teaching ourselves to some extent, which was fine. I mean, I feel we did that quite a bit.
Right, exactly. I mean, that's part of the job. It's part of what makes interventional radiology fun. So let's talk about how you started doing it with gallbladders. What were your first patients like? How did you get started?
Yeah, so those first patients were definitely those sick ones. And there's a great case that I remember, and Bill and I did it together. It was a patient that she was in her 90s. She had acute cholecystitis. This was, during COVID. Was a surgical candidate, but didn't want surgery. We ended up placing a bedside chole tube, and she just didn't want to undergo a major anesthesia event, potential risk for converting a laparoscopic cholecystectomy to open, maybe comorbidities with that. And so we said, okay, we can try to get these stones out. And for her, it wasn't one big stone. It was kind of like a bag of small stones. And so Bill and I were trying to figure out the best way to get those out. And we knew that we had a scope, that we could use, and we knew that we had a basket. And so our initial thought is, okay, we're going to basket these out. And I remember in the beginning of the case, we started that. We took the chole tube. It had been there for several weeks, allowed the infection to cool down, brought her back as an outpatient, did it with some max sedation, upsized to like a 14 French sheath.
Okay.
And we started basking it out like, this is great. It's taking forever. Because it was like it was all stones. And so we said, okay, let's start upsizing. And then we started upsizing to like an 18, like, okay, stones are starting to actually kind of come out of the sheath now. And then we thought, okay, what if we go like larger? And we kind of used some PCNL tools that are out there. Yeah. So we used the X4 sheath, which went up to 30 French.
Yeah,
and
we use the same thing.
Yeah, that and then Nephromax is one that we now have in MedStar. So these are PCNL. It's there's a balloon catheter, goes over the wire, and you kind of screw the sheath forward as opposed to just shove it in, and you keep the balloon inflated as you do it. And we felt comfortable doing it, so we went ahead and upsized to a 30 French system, and then the stones started pouring out.
Is it hard to get the Nephromax in? Because, I think about when I put a Nephromax into a kidney, I'm kind of twisting it in, and I can really push against that thing. It's kind of firm. Gallbladder can be a little wiggly. Is it tough to get it in?
Yeah, so it's definitely a different field in the kidney because, the kidney, you're in the retroperitoneal space. You have a nice kind of boundary there that stabilizes the kidney to some extent. You can absolutely push the gallbladder away with this. So there's definitely a learning curve to it. Now, I will tell you that I've done at this point probably close to maybe 80 to 90 de novo accesses where I've upsized from, nothing to your 24 French system. However, it's definitely a learning curve. You can shove things away. I think the important part is really that corkscrew motion of the sheath, twisting it on, as opposed to allowing it to, to push forward. Because if you push forward without getting the little bevel lip of the sheath in there, that's going to push everything away. And so, yeah, but I've definitely seen the gallbladder start to move forward. Harjeet talks about this kind of like invagination of the gallbladder. You can see under fluoro, if you have contrast in it, that happens too. So definitely a little nuanced for sure.
So anyway, I interrupted you. You get the sheath and it starts pouring out.
Yeah. So it starts pouring out. And the way that we did it was we thought that irrigation would be better than basketing because they're pouring out, the basket's kind of there. And so we ended up disconnecting the irrigation pump from our cholangioscope, and we used a single action pump syringe, which is, again, something out of the urology side of things. It just spring loads connected to like a saline bag. We connected that to a sauce, and then we had a partially inflated 5.5 Fogarty, and we led with the sauce into the gallbladder, and then a Fogarty behind it in the sheath. And so we would irrigate through the sauce and then pull the Fogarty and the sauce back in tandem through the sheath. And we called it kind of like a double catheter technique of flushing to create a negative suction through the sheath and pulling kind of these stirred up irrigated stones. And that cleared the majority of it until we didn't get any more stones out. Then we went back with the camera and basketed things out. And so we had a bowl on the back table just full of stones. And one of my fellows at the time said it looked like a bowl of kibble.
Nice. So where did you go from there? I mean, your first case sounds like it was a success. So actually, how did you close? I mean, what did you finish off with there?
Yeah, right. Because, we're going from, an 8.5 French tube to a 30 French system and then need to downsize it. And so we used a 14 French tube to close at that point and purse string it around there, let the patient know that there's going to be some leakage on the dressing. And then we brought her back, I think once or twice more to put the camera back in just to make sure there's no straggler stones and eventually pulled everything. And she did great. And her granddaughter sent us a picture several months later at her gambling at a casino because that's just what she wanted to do, without a tube, and she was very
That's
happy.
great.
Yeah, so I think that case taught us a lot. It taught us that, one, we felt comfortable upsizing to quite a large system, and two, the irrigation technique may be faster than just basketing, and three, that you can actually close these using obviously a smaller profile tube than the sheath that you're going to place in there.
So talk to me about how the procedure evolved and what changed and really how you got from there to where you are now with this.
Yeah, so you start taking these on, you're going to get more referrals, hopefully, more patients kind of seeking this out, or certainly surgical teams saying, hey, I can't do anything for this patient. Can you help out, at least from the gallstone perspective? And what may happen is you'll find more challenging cases, larger stones. And I think that tends to be a point of discussion is, okay, well, you have the small stones, what about larger stones? What tools can you use? And that's when you start exploring different ways to break up stones. And so, just kind of evolve your practice a little bit. The cholangiscope typically has an irrigation channel to it, but there's also a working channel that you can put in baskets, you can put in fibers. So EHL, which is hydraulic lithotripsy, that's a fiber that can fit through there. It's a foot pedal system with a generator. It maxes out a certain number of pulses, but that will actually mechanically break up the stone. So that's one way to tackle it. Then you go into, off-label laser fibers. So holmium with holmium lasers, which you can get through different companies like Agility and Fortec will supply it. So they'll supply those laser fibers to you, and you can go in, select your energy levels, which does require, I recommend, some conversations with people that have done it. And that will also destroy the stones. Also, not a bad option for strictures as well. The big guns, as I like to call it, which is using really the dual energy, ultrasound frequency, and suction. And Olympus makes the device called Shock Pulse. Boston makes one called Trilogy. That's truly made for, the urologist tool bag to fit through a rigid nephroscope, but it's a device that will really mechanically destroy and eradicate large stones. It makes kind of short work of it. And I think Bill also had this one case with a pretty large stone. And one of our colleagues, Tim McClure, who's urologist and IR, was walking by, and Bill was chipping away at it with a laser, which would have worked, just take forever. And Tim said, why don't you use this? And that thing, took 15 minutes to break away. And in my practice now, I personally use that device quite frequently for most of my stones. And so even 5 centimeter stone, once we get there with a rigid nephroscope and then the shock pulse, obviously, off-label use for these things, but we can get rid of those stones in a matter of, maybe 10 to 20 minutes, depending on composition. Yeah.
And they're super fun to use.
Very fun to use, very
It's
satisfying.
It's like video game,
It really is.
I've only used it in the kidney, but they're a blast.
Oh yeah, it's awesome. It's pretty impressive how fast you can get rid of these stones using those devices. I mean, they're very effective devices. The nice thing too is that, aside from the shock pulse or Trilogy probe itself, everything else is reusable as opposed to disposable. And so there is that, a cost perspective associated with that. I think it does make a big difference.
Yeah. How do you choose patients now for this? Like patient selection obviously can be very important, but how do they end up, do you see them in clinic, or are these inpatients?
Yeah. So, it's interesting. When I first got back to MedStar and really wanted to expand that program, we were identifying patients, and this is like in 2021. So we were identifying patients that were coming in for routine exchanges that had stones and were non-surgical candidates, and we would kind of get those patients. And maybe they had tubes in for 6 months. Some of them have had them in for a couple of years. And so we were truly actively identifying those patients who would come into IR for their routine exchange, then talk to them about it. So that's like the first subset, the first way to grow it.
I mean, it's maybe the best one. Those are those challenging patients to deal with. And, everybody wants to get those patients fixed, especially the surgeons,
Yeah, exactly. And so we really would, focus on those patients to start growing things, and then maybe letting the surgeon know who we worked with that, hey, so we were able to take care of this. If you have other patients that you're seeing in clinic, let us know. And so that's what we did, is we approached our surgical team. We have a very good relationship with them. Our trauma surgeons do the majority of cholecystectomies, at least at one of our hospitals. And we obviously help out quite a bit with trauma there from the IR side. So we place a lot of chole tubes as well. So they knew us, they knew what we do. And we told them, if you have patients that, you're seeing clinic, let us know. We'll see them in our clinic and talk to them about what are the options. In addition to then approaching patients when we get consulted for a cholecystostomy tube placement with a stone, we will now tell them, listen, if you're not able to have surgery for whatever reason, we have an option for you that's available. And usually we'll follow them up in clinic after they've been discharged at that point, just to have a conversation again about what, the gallstone removal process looks like, letting them know that's usually not just one step, it's probably a couple of visits with us. Also letting them know the other options that are out there, which is just routine exchange or potential capping, potential removal, to letting them know that there is a 20-30% chance of recurrent cholecystitis, which is also what we've seen in our practice as well. So it does amount to another clinic visit, to go over the procedure again. But frankly, we are now identifying the patients in-house, inpatient, and usually having a conversation with them prior to their initial discharge about this option.
Okay. So it's never like we find this, you see this patient in the hospital. It's like, let's go get these stones out today.
So we have done that. We've done that in very certain circumstances. Usually it's like a social barrier or something that would prevent the patient from easily coming back to the hospital. We have a decent undomiciled patient population that can't maintain a tube for a long period of time. And so, part of what we try to do is, if we have a way to get their tube out, would be to get the stone out first. And so we'll do the stones out as an inpatient, then the tube out before they actually are discharged from the hospital.
But ideally, you put the cholecystostomy tube in and then let everything cool off, follow up and have that done.
Yeah, for that patient population, the sick patient. Yeah, exactly. And we used to do a very prolonged time period because we were obviously being very conservative with this when we started, meaning that we would allow 4 to 6 weeks of tract maturation as well, then bring them back and do the actual upsize of the sheath access and then stone removal, and wait maybe a week or two, then bring them back and either do what I call a second look cholangioscopy, put the camera back in to make sure everything's gone, or just do a squirt and pull of the drain. We now have shortened that timeline quite a bit. We'll honestly, as soon as they're done with their antibiotics, usually it's about 2 weeks after initial chole tube placement, we'll bring them back and get rid of the stones at that point. So it just, results in a longer tube length for the patient.
When you do the cases, do you typically do them under sedation or anesthesia?
We usually have anesthesia involved with them, just because it can be a little bit painful, especially with the upsize of access. Yeah, so it depends on the case, though. If I know that we have kind of small stones to go after, I can get away with like a 12 French sheath and it's not as big of a concern, but we'll often have our anesthesia colleagues involved. Now, whether or not it's general is a different story. They may elect to do MAC for those patients. Again, a lot of these patients, especially when we first started off, have a lot of other comorbidities that are there that maybe prevent them from having full GA, and we'll kind of, help them out as best we can from the sedation standpoint, even if they're not intubated.
A couple technical questions. Do you have to consider your access when you're doing this for the first time? Like, hey, we may end up doing cholangioscopy on this patient. I don't know what it's like. Are you still trying to go transhepatic when you're considering putting a 30 French catheter in?
Yeah, so actually I prefer going transhepatic for these because I think it does stabilize the system. It also, in my opinion, prevents leakage. So I still try to do transhepatic. I think more importantly, though, I'm thinking about the fundus of the gallbladder when I'm accessing. A lot of times when we're doing a per chole, we're just trying to get something in the gallbladder and get in and out. It's not a very long procedure. Now I think about, okay, let's identify the fundus, because if I need to go back, that's going to make the whole process a lot easier. It's so much so that I've had patients where it's a body access, gallbladder body access, and then I'll actually re-access into the fundus on the day of the procedure. Yeah, the reason is if you go into the body, I mean, believe me, you can get the case done. Like you'll be okay, but you'll be torquing quite a bit, and you can use your sheaths to torque as well to aim towards the fundus to make sure it's clear. Whereas if you come at the fundus, you're having kind of a linear pathway towards the neck and cystic duct. It makes the whole procedure just much more efficient, a lot more bearable. And sometimes it does mean reaccessing the gallbladder. I have never regretted reaccessing the gallbladder for that purpose. I've absolutely regretted not doing that.
Okay, that makes sense. What about, in terms of so when you bring a patient back, the patient has a cholecystostomy tube. Before you put the sheath in, are you squirting the tube?
Yeah, so I inject the tube every time. Same thing if I get de novo access, I'm injecting. What I'm looking for is not only the filling defects, I want to assess the patent cystic duct to see, if contrast is flowing or not. Half the time, the cystic duct is occluded. There's something there. It gives me a little information if I need to go chase something down the cystic duct, especially. So I always inject, yeah.
Well, so that's where I was going with this. What do you do with an occluded cystic duct when you're working on the gallbladder?
Yeah, so if it's related to inflammation, right, it's just the stones that are kind of stirring things up. Clear out the stones, try to get that nidus inflammation out, have them decompress to a bag for about 2 weeks, and then bring them back and take another look. If there's contrast getting through the cystic duct, but there's very clearly a filling defect in there, meaning that a stone is migrating there. Or if you see the entirety of the cystic duct, but not the CBD, you can probably assume that maybe there is either a stone or stricture, the confluence of the cystic duct and common bile duct. Then I'm trying to get down. I'm trying to get into the CBD.
And you're doing that from the gallbladder?
From the gallbladder, yeah, transcystic approach, yeah. You can use a stabilizing sheath to get a directional catheter in there. Honestly, like a glide cath with a glide wire or glide advantage, something of that nature. A torque device will get you there. I've definitely done it with a smaller system if I needed to, like an 018 glide advantage as an example, and then a Navicross if it's very tight or tortuous. But if you find contrast does go through the cystic duct and you see something occluded, then it probably is the best thing to get a wire down there, get it to the duodenum, and get a transcholecystic internal-external access at that point. Whether or not you need to advance the scope is a little bit of a different story. So if you are using something like Spyglass, it can fit through a 10 French sheath. I like a 10 French bright tip for these because you can pop off the hemostatic valve and you can pull things out like stones without losing it due to the hemostatic valve. But it's a pretty big profile system for the cystic duct for certain patients. So it's just something to keep in mind. That being said, if you see stone or anything like that, you can actually advance a Fogarty balloon distal to the stone and inflate it a little bit and pull it back into the gallbladder. Or you could push it out that way as well. If you can get the scope down, you could probably basket the stone, you can laser the stone, or use EHL for the stone. But more importantly, that's when I'm getting down the cystic duct and out.
Down and out, you're getting a stone out if it's there. Are you leaving anything across the duct?
Yeah, absolutely. So I'm leaving usually an internal external biliary drain. And oftentimes, if I think there's anything wrong with the ampulla, maybe I've also done a little bit of cholangioplasty down there on the sphincter. So I'll leave something, really across there. So internal external biliary drain will work. You can also theoretically leave the pigtail loop above the ampulla in the CBD. So is theoretically not to allow bacteria to kind of go back and forth more easily. But I am typically leaving something across there because I'm creating inflammation. Also, if there's concern for stricture, and let's say you balloon that, one, you might perf, right? You might cause some dissection there of the cystic duct and you need it to heal. But having a drain across will allow the cystic duct to start healing around the drain, create a little more buffer for it. And then what I would do in that case is when I bring them back in 2 weeks, and do an injection, pull the tube back, maybe put a sheath, do a pull back cholangiogram from the CBD into the gallbladder. Either remove it at the time if you feel confident, or convert it to a chole tube and start to downsize everything to like an 8, and then potentially bring it back one more time to remove everything.
Okay. I know you've done a lot of these cases. Are there any common complications that you've seen?
Yeah. So one of the risks that I talk to every patient about is drop stone. And it's interesting because we sometimes get consulted for drop stones in patients that have had a cholecystectomy, right? And it may be years before it presents as an infection, but we've seen it. And I think there's enough of us out there that have actually used the scope and tools to get rid of that stone. You get your abscess drain in place, and you're going to upsize, having a sheath there, and then identify it and use some device to take it out. But it's something I absolutely caution patients about. I have not seen it in my personal practice yet. It's probably going to happen at some point. The other things that you want to worry about are perfing the gallbladder. Obviously, we're coming in from one end, but you could theoretically push forward and perf the gallbladder through the other end. I caution my residents to really watch their wires. We do a lot of this over the amplats. And if you start having a kink in the gallbladder, because typically, the wire's looped, it's not that hard to kink it, you can easily perf through the gallbladder on the contralateral side. If that's the case, then, as long as I'm confident that I'm in the gallbladder, I will leave a drain behind, stop the case, let everything heal up. Usually about 2 weeks later, 3 weeks later, everything looks fine and you can do the case safely. But these are absolute things that I caution the residents about and fellows about. And I've definitely seen a perf on the contralateral side just purely from upsizing the access. So it's something to be mindful of.
When you're upsizing the access, do you go straight from your cholecystostomy tube to the nephromax, or do you kind of serially dilate?
So you mean in the procedure or like over a period of time?
Both.
So we used to do this kind of interval upsize where we would go from like an 8 French or 10 French to a 14 French, like maybe 2 weeks later, then bring it back for the bigger procedure. And we moved away from that just, again, based on experience and comfort at this point. So I oftentimes will upsize the 8.5 French chole tube to a 24 or 30 French system in the same setting. What I'll do is I'll often just go to the nephromax, although randomly I had a tech drop a bunch of dilators, vascular dilators on my table. I'm not really sure why. He dropped a 10 to a 14. And I said, well, they're here. I'm going to use them. And that, for whatever reason, seemed to make everything go a lot smoother. And that's kind of now what I do. I'll do a little bit of serial dilation from the 8 to a 24 or 30 French system. I'm not sure if it's just maybe breaking a little bit of tissue up that makes the balloon a little more efficacious in terms of getting everything expanded, getting the sheath in, but that's what I do now.
Yeah. One thing that's a challenge for me when I'm doing these cases in the kidney is really finding the ideal angle of the II to line up and get the sheath in. And how are you doing this for the gallbladder and making sure you're looking at this the way you need to, and also evaluating your access?
Yeah, so that's a great question. And it's not infrequent, right, that we are, it's not infrequent that we are accessing at a certain angle, maybe the tube's at a certain angle, and you're kind of looking at an image if you're on the AP, and you're like, okay, I'm trying to track my tools over the wire, and it's not making sense. If you go to an LAO, that's probably going to straighten things out for you pretty well. So LAO is pretty standard. I keep my foot on fluoro as I'm dilating, and certainly with the nephromax, what I'm looking for is one, that kind of loss of the waist of the balloon, but also making sure I'm not pushing anything too hard into the gallbladder. So I honestly will pacify the gallbladder with contrast at this point for that initial cholangiogram, and then I'm using that as a kind of a marker for how far to push everything in. The balloons on the nephromax, balloons on X-Force have radiopaque markers. They're distal and proximal, but the distal one can kind of get lost with all the wires and contrast, so you just have to be mindful of it as you're pushing. But LAO typically will do it. And then I've gotten to a point now, and it took a lot of time, where I will actually move fluoro just out of the way. I'll move fluoro to the head of the patient once I'm in with my access and just rely on the scope. I found that I would be heavily relying on fluoro, less on the scope, and it would make the case a little bit longer. Since I've just physically got it out of the way and you start to really depend on the scope a little bit more, it's actually made the cases a lot faster.
Okay, that makes sense. So just, if you don't mind, tell me a little bit about what else you guys are doing in the biliary system using cholangioscopy.
Yeah. So, fortunately, again, we have a pretty collaborative group here between GI and hepatobiliary surgery and trauma surgery. So, beyond the gallbladder, where we do a lot of work, we also do intrahepatic biliary work as well.
Okay.
Oftentimes, the algorithm for that is, let's say a patient has elevated bilirubin, found to have intrahepatic biliary ductal dilation on imaging. GI tries to do ERCP, can't get up, and then we get called. Or they may actually now call us in advance to say, hey, I don't think this is going to be successful. Can you guys consult on the patient as well? And then if we fail, are you there? And so it started with that, right? We would go in, place a biliary drain And then in the case of, let's say, a malignancy as opposed to a cholangitic patient, we would go ahead, put the drain in, and then I would upsize to like a 10 or 12 French sheath, put the scope in, try to identify based on fluoro images where that cutoff is from the cholangiogram, and then identify that irregular mucosa with the scope and use a clamshell biopsy forceps through the scope to really take bites out of the tissue. The reason that's important as opposed to just a brush biopsy is that those biopsy samples you can put in formalin. The pathologist can actually run stains on what you get from the clamshell as opposed to more of a cytopath, which is what you get from the brush biopsy. So that's the easy way to start, with those cases is helping get a diagnosis, and then subsequently, once you get past that area of stenosis, you can discuss patient's going to go on chemotherapy. Great. If not, okay, is there a role for stent placement? Things like that.
How big of an access do you need for just the clamshell biopsy?
So the clamshell biopsy, the ones that we use, a spy bite is one of them. It actually fits through the spyglass. So your overall access is going to be what you use for your scope. And so typically for the intrahepatic biliary system, I do not go above 12 French. That's enough to comfortably move the scope. If you want to go smaller, 10 French works too. It's tight, but 10 French works too. I have gone up to 24 French for a very different reason, a very special patient where we had to use shock pulse to get rid of this huge conglomerate biliary stone for a patient, but different story, different scenario. It's not our typical algorithm for that.
I think that's like the only case that I did in training was a case like that with a giant access and stones throughout the biliary system.
Yeah. I mean, sometimes you have to go big. We published a couple papers on what we call large bore access for this stuff, and it works well. But the one case we did, since we're on the subject of it, was this this patient that had a right hepatectomy in like 1996, had a hepatico-J and had recurrent stones and subsequently had recurrent infections because of the stones and biomas, and was going on for this 20-year period of having things drained and having drains removed and replaced, and drains removed and replaced. And finally we got consulted a few years ago, like, is there anything we can do? And so brought him in a clinic, talked to him about all the risks and benefits, and said, okay, we're gonna try to get rid of the stone, thinking that's a nidus of infection. And so we used kind of a long path to the biliary system through the liver, is based on where the access was at that time. Started with lasering it, which was fine. Laser was working. The problem is he had a little bit of stenosis at the hepatico-J. And so when you're lasering, you're dusting. And if you're using irrigation, that dust has nowhere to really go if there's a stricture, right? It's not going to go into the jejunum very easily, so we can't see. So we're doing this for like 30 minutes, and then finally said, okay, what if we just upsize and just put the nephroscope and shock pulse in, and bit the bullet and did it. And man, that just flew. That case flew.
Yeah.
And I actually saw him for 2-year follow-up a couple of months ago, and he's with an MRI and no stone recurrence whatsoever. Yeah, the guy's doing great. He's happy. So anyways, that's a very unique case. Not usually what you start with.
Have you found cholangioscopy to be a useful tool in helping manage strictures?
Yeah, so strictures are tough. And I talked to a lot of my colleagues throughout the country about this. Pramal Trivedi, Ravi Srinivasa, Austin Riaz have a lot of experience with it, and they're all kind of using different techniques for it. I think strictures are very, especially benign strictures, are very tough because they're very recalcitrant to a lot of techniques that are out there. The way initially, we're all taught, I think, how to do stricture management is you can do serial upsize of your tubes. You can do the, the double dragon technique, where you have an 8 French through a 14 French tube, which does work. It just takes a lot of time, several months to kind of stretch things open. You can do obviously cholangioplasty with a large bore tube that's in place, like a 20 French. And so all these work to some extent. There is obviously recurrence rates that are associated with all these techniques, like anything else. So a lot of us across the country have been thinking about how do we use a scope to help with stricture management. So the same lasers that we may use for stone removal, albeit different energy settings, we can use for stricturotomy, where we identify a stricture using the scope, and then you point at it and you use the laser to create a cut, more or less, in the scar tissue and try to shave it off. And there's been a wide variety of techniques that have been described for this, and I don't think anyone really knows the best way to do it. There's that chevron technique where there's 3 incisions that are made, and then some plasty to stretch it. Some people just do one incision, and then others will just try to really just get all the scar tissue off, so you get a little bit of bleeding to your unhealthy tissue, leave a drain behind. And then there's also the Habib laser. Now the Habib is it's RF actually. It's an RF wire that can have a circumferential destruction of tissue. And I think Austin probably has the most experience, Austin Riaz at Northwestern. But we talked about it at SIR during the deep dive, and he's had some just phenomenal results for using that. Now, the way that it's used, it's an over-the-wire technique, and so you can't actually fit it through the scope. So you use the scope to visually identify the areas of stricture, and then you map, compare it under fluoro, and you're going to have your fluoro images for your actual Habib to kind of go over. So take the scope, identify on your fluoro image, maybe mark it on the screen, put a wire in, put the Habib over it, and then pull back as you're ablating, put the scope back in to make sure everything looks good. So Austin has some fantastic data, and probably more importantly was after SIR, I went to Pairs in Dubai to talk about this stuff. And what was interesting is that this globally, people are using this. It's not, this is being used elsewhere. So I think that has a lot of promise to it. My experience, I've used the laser and it's worked very well. And so I think there's a lot that's going to be forthcoming with different ways to manage strictures, but it's tough. Strictures are just notoriously hard.
Right, of course. Just a couple more questions. What has your experience been working with primarily surgeons dealing with the biliary system and gallbladder?
Yeah. So just with surgeons themselves, you mean?
Yeah. I mean, these are challenging patients for everybody.
Yeah.
Gallstones, acute chronic cholecystitis and biliary strictures, you're adding something to this, but to me, it just seems like, you're not really taking anything from them. It's not like, prostate embolization, for example.
Right. Exactly. So I have found this to be incredibly collaborative with our surgical teams, and they're very receptive to it. When we started the program at MedStar, really started building it rapidly when I got back there. The first thing I did was meet with our surgical team, and then I kind of gave they had like a morning conference where I talked about it and talked about what we were doing. And it's really filling in a gap that's there. And when we talk about the gallbladder itself, I mean, these patients are really otherwise kind of left to just have either drains exchanged or maybe recurrent infections down the road. And so I think we're filling in something that just wasn't there, and we're not taking anything necessarily away from the surgical teams. And it provides just another option for these patients, so much so that the surgeons now, again, included in their notes when they consult on the patients too, please, contact IR for this. So it's been just absolutely great. And also with GI, it's been helpful too. If they have a patient, let's say they get consulted for ERCP because of choledochilothiasis, the patient has gallstones, that's where it came from. They'll reach out and say, hey, what do you think about doing a cholangioscopy for these patients and gallstone removal? In a similar way that our hepatobiliary surgeon, GI team and us, we've had many shared patients where they have either stones or strictures or whatever, and we'll kind of talk about it in multidisciplinary fashion to find a way where we can all either get involved or maybe someone has the better way to do it, and the other one will just kind of take a step back. So if anything, it's only expanded the number of other service lines. I know that we do it, and it's only brought in more patients for us.
Right on. Last question I have for you is, what is your advice to people out there that are considering taking this on and don't have experience with any kind of endoscopy?
Yeah. So, I mean, reach out for one. If anyone is interested, I'm always personally happy to talk, and we have a lot of resources through the society SIR now. We're going to be actually having this at Edge. I'm one of the course planners. Yeah. I just got added on. So that'll be in San Diego.
Edge sounds like it's going to be awesome.
Yeah. It'll be fun. We're going to have, this will be part of the portal hypertension biliary section. And we're going to have dedicated lectures of cholangioscopy, hands-on with models and things like that. We're probably going to hopefully replicate the deep dive we had. And so I think coming to these things to get the hands-on, learning the equipment, even getting contact information if you need like a rep to help support cases, or honestly, just talking to any of us who do it, because we're happy to encourage and build this out. I think one of the important parts too is knowing how to bill for this. I think it's actually very important. At SIR, we had this deep dive session for cholangioscopy, and in the first lecture we had, Joey Miller gave a great talk on the appropriate billing and coding for this. It was supposed to be a 15-minute talk. I think it took like 45 minutes with all the Q&A because it was just, people had a lot of questions. But understanding the billing and coding is going to be very important, so you're not really leaving something on the table. And this may be something where in a group, you may not have the CPT codes already built out for it, and you need to build those out, and they need to be the appropriate codes. When we first started looking into our billing and coding, we were absolutely not billing this correctly, 4 or 5 years ago. We just didn't know how. And now there's a lot of information out there. I think SIR, based on Joey's talk, has some handouts that have the appropriate billing and coding, so you can actually, get reimbursed appropriately for these procedures, which, in my opinion, is incredibly important as you build out this practice. But also, in general, to how to get patients, how to do things like that. I think identifying patients with chole tubes that are not coming out because of gallstones and they're never gonna have surgery, that's an easy place to start. Also, doing the intrahepatic biliary work, being available to either scope and get a biopsy or scope and maybe get rid of a choledocholithiasis that GI can't get to. Things like that will kind of get your foot in the door, get the conversation started. And after you've done a couple of these, it'll kind of spread around the community that, this is a service line that IR can do. It fills in some gaps that are there for patients. And it's a very, I think, meaningful procedure that is still evolving, but we're trying to get more and more people doing it and more people comfortable in it.
Fantastic. John, that's about all I got. Is there anything else I'm missing?
No, I mean, always feel free to reach out if you have questions, need more information about building a scope practice and how to scope. And we're trying to get more and more of this at SIR, the national meeting. So look out for Edge.
Awesome. Thanks, Van.
All right. Thank you.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza,
Sabine Dond,
and Aaron Fritz. Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.